I posted this morning's class, which was a little obviously longer, into your shell as well. And well, tonight we're going to talk about cardiology. We'll talk a bit about drugs. We'll go through. I suggest that you take a look at the videos. I will tell you right now, the arrhythmia video is not available. It has been, YouTube has taken it down. Yeah, well, YouTube took it down for reasons of probably material used in it that was not used by permission. So I suspect that somebody tried to do a nice educational video, found some nice diagrams and pictures and stuff and information that they just used without getting the appropriate permissions. And so YouTube pulled it. Got a problem? Oh.
Sorry.
All right. All right. So tonight we're going to talk about cardiology. First off, any questions? Oh, good. All right. Not a problem. I have not had a chance to grade the Framingham study documents that you put in, that you gave me. I will try and get those graded over the weekend. And we will talk here about a few other things. Great. Got it. What I am going to do is give you about cardiovascular. There is a video on the heart in the shell. It's probably a video you've seen before in your cardiopulmonary ECG class. However, you might want to review it because it's actually a pretty good explanation of not just heart anatomy, but how blood flows through the heart to the lungs, back to the heart to the body. So it's actually it's a Khan Academy video, so it's pretty high quality, and I found it useful as a review this morning with my class. So go ahead and do that. Let's see, I want to share screen. I get the right thing here. All right, that isn't going to work, therefore. Okay. All right, so here we are. You've turned in the Framingham risk assignment. You'll be working as a result of tonight's exercise. You'll also do the cardiovascular, respiratory, and dermatology assignment. Okay, so Charity is now online as well. Good. That's good. So you also have the week 2 assessment. Some of you have started it. Remember, you can do it multiple times. So there's no time limit. So work on that through the rest of the week. The videos that we have The video on calcium channel blockers is it's sort of like, it's almost an anime. It's that kind of artwork. And it turns out to be pretty academic, but it explains things pretty well. So you probably want to look at that. The videos about the respiratory conditions, beta-2 agonists, which the beta-2 side of the beta agonist tree is respiratory in action. So there's a short video on beta-2 agonists. There's a short video on bronchitis, COP, and asthma. You may not be able to view it directly in Canvas, but if you look at the bottom of the YouTube field, you can click on YouTube and it will take you to the video. So you can see it if you haven't already watched it. All right. Okay, so we're going to talk now. If you have questions, what questions do you have? Any? All righty. Well, in that case, we're going to go to the cardiovascular. Why is that not working? Okay. We'll try it this way.
It could be that Canvas has been being pretty iffy. I don't know if that was anybody else, but it was weird for me this morning. I tried to get on and check my grades because I got notifications that Chantal was grading stuff. It was weird. It's since stopped, but it was weird.
Mm-hmm. Yeah, well, I had to do a webinar this afternoon for the company, and our network went down. So, yeah, it was a pain. Yeah. However, these things happen. Didn't stay down, but it was still a pain in the neck. So nonetheless, when we look at the cardiovascular system, what we have is something that is the heart and the blood vessels. Now, the heart may be localized in the upper left quadrant of your body, but the blood vessels are everywhere. But it's intimate, and it is intimately connected into the pulmonary system for obvious reasons. The heart is a pump, and it, as a rule, it is probably the busiest organ in our body. Okay, with the possible exception of our brains. Actually, our brains use more energy than any other portion of the body. But the heart clearly works. If we look at the anatomy, we all know the blood moves into the left atrium from the body, from the various veins of both superior and inferior vena cava. Moves from the left atrium into the left ventricle through the tricuspid valve. And then from the left ventricle, it's pumped into the heart or into the lung, returns from the lung to the right atrium, is pumped into excuse me, I've got it just backwards here. Our blood goes into the right atrium from the body, and then into the right ventricle, then to the lungs, then back to the left ventricle, and then out of our left atrium. Atrium is just a Latin word that means entryway. So it's the entryway to the heart. So it goes into the left atrium and then into the left ventricle and is pumped into the body via the aorta and splits. So all of this is electrically controlled. Every single part of this can have a problem associated with it. The heart as a muscle has its own circulatory system, and the arteries of the heart can become diseased, can become clogged, can have plaque buildup, requiring either some form of cleaning out, a procedure that people who go through it says is like a Roto-Rooter. Yeah, but there are lots of ways, or in extreme cases, by bypass graft surgery, in which the actual blockage is localized, and then a small piece of vein is harvested usually from the leg, and then stitched to bridge across the blockage. So they just basically put a piece of vein at one section of an artery and bridge over the clot and stitch it onto another section of the artery. Emily? Is the reason what?
That the vein is taken from the leg?
Well, if it's the leg has some good-sized veins that are close to the surface. Plus, we want these to be allografts, right? We don't want autograft. So but the leg happens to have some good ones that are good-sized, and the body has a really good talent. When you take out a chunk of vein, they can either they only take a little bitty piece, so they can probably stitch them back together. But even if they can't, the body finds ways around it. So the body is really clever, but they do all that repair. But the leg is convenient, and the anatomy is well understood. So we use that. You can have multiple surgeries to replace those, to graft on those venous pieces. But it seems to work pretty well. But heart surgery, open heart surgery, is always risky. But the heart itself is a pretty complex organ rather. It also, if you look at how it works, I'm not going to go into the full A and P of the circulatory system. You already know that. But the heart itself, we remember that veins carry carry blood away from the heart or toward the heart. The venous blood is generally deoxygenated, except the pulmonary vein, which is oxygenated blood. So veins come toward the heart, arteries go away from the heart. So and every artery except the pulmonary artery carries oxygenated blood. We won't go into a lot of that. I'd like to go into if we look at a picture here, and I'm looking now at slide 13 of the thing. We have a good idea of the coronary arteries. They're numbered here. There are 5 of these things, and any of them can be blocked at any one spot. What happens when they're blocked is it cuts off blood flow to the muscle that's being served by those arteries. The muscle within a few minutes begins to die because it's not getting oxygen. And it creates an area of non-functionality we call an ischemia. Ischemia simply means that it's blocked and it's not working. If the damage is not real severe, the body can develop alternate paths for blood flow to make sure that we can continue to keep the rest of the heart working. And these smaller areas of ischemia are replaced by connective tissue. Eventually, the body does, because you're not going to put new muscle in there. You will know if you have part of your heart die. It's a heart attack. Now, there are degrees of heart attack. In some cases, the damage is relatively, I'll call it small. I mean, any damage to your heart is not fun. It's not simple, and it's not a little. But you can still have a functioning heart. The problem is once you have one heart attack, you're more likely to have another. The other thing that happens is you are more likely to develop things like blood pressure problems, dysrhythmias, and congestive heart failure. Your dad what? Has had 4? Well, he's lucky to have survived 4. How old is he? He's very lucky to have survived 4. So I hope he keeps on surviving and doesn't have any more heart attacks. The heart is an electrical machine as well. It's powered by the nervous system in the heart. At the right atrium, you'll find the sinoatrial node, which is a bundle of nerves that act as the pacemaker for the heart. They drive everything else. The signals will go from the SA node and go to the atrioventricular node, which is at the junction of where all 4 of the chambers meet, and then sends it on. And it can act as a backup to the SA if it has to. There are bundles of nerves that carry current down through the intraventricular septum, the barrier, into what we call the bundle branches, and the bundle branches carry impulse to the ventricles through fibers, nerve fibers we call Purkinje fibers, and they spread. They initiate contraction at the right and left ventricles, and all of this is, of course, in the body. We don't have copper wires. We have nerves, and so all of this are based on chemical processes that set off something that can be detected as an electrical signal. The electrical system is diagrammed here. You see the SA node, the various bundles that come off the SA to the AV node, and then the other nervous conduction pathways that go to the left and right bundle branches of the heart. It's not, obviously it's a bit more complicated than that. This is the signals that as these nerves are firing and working are what we measure in an ECG. And an ECG tells us what kind of ECG tells us what kind of rhythmic problems the heart is having, and we can tell. We have a pretty good understanding of this. What you're seeing in the picture on slide number 14 is a picture of what is considered to be a normal sinus rhythm. And have you all had ECG? You all had it, right? You haven't had it? Okay. Well, you'll have it soon. Yeah, I'm not sure what's going on next mod. But that's a class that Nate generally teaches. There are lots and lots of different rhythms. We'll get to arrhythmias in a bit. So the conduction system is illustrated in this schematic on slide 13. And again, we have the SA node, which fires, signals the AV node. We have all sorts of things going on, signals going over and activating other nerve bundles and causing this to happen. When this is working right, it's a very regular sort of beat. If we just take a look at a normal resting EKG, it's divided into waves and complexes. The P wave, the one on the left of this diagram, is what happens when the SA node fires, causing the atria to contract. The QRS complex here is related to the AV node receiving its signal and sending it on to the ventricles. And then the T wave at the end, this is not the only thing here, but the T wave at the end resets everything, a process we call repolarization. Okay. So that YouTube, let's see, no, you can't, you'd have to copy it and paste it, but is pretty good actually. So a normal EKG is going to look like this. There's also out here past the T wave, occasionally you'll see a U wave, but not always. So in simple terms, we pump blood through the heart. Via the heart, the blood is pumped into the body, and we have an electrical system that maintains the rate, and the rhythm requires oxygen. It's controlled by the autonomic nervous system. We talked about the autonomic system a bit on Monday night. The sympathetic side increases the rate and force of a heartbeat via the SA node, and the parasympathetic side will decrease the rate via a different nerve, the vagus nerve. Okay. What does the heart do? Well, heart output, blood is really looked at as a result of the pressure that is exerted by the heart as it pumps. And as we know, there is when the ventricles pump, they're squeezing blood into the arteries. So that's what we measure when we measure systolic blood pressure, the force with which the ventricles are contracting. The diastolic pressure is the force when the ventricles are relaxed and the atria are doing their stuff. So there's a range there. So a blood pressure is actually composed of the actual output, because the heart does largely empty each chamber as it pumps. Pooling blood is bad, and we'll talk about why later, but pooling blood is bad. So as each chamber empties, it pretty much empties its entire contents. Not all of it, but pretty much. So we have cardiac output, blood volume, and then the resistance that is met on that pumping that is related to the diameter of the arteries into which the blood is being pumped. Okay, does that make sense? Okay, so cardiac output is related to is basically defined as the amount of blood pumped in 1 minute. It's always defined as the left ventricle. Higher cardiac output is related to higher blood pressure. Okay. Cardiac also volume is also what we call stroke volume, which is the amount of blood pumped by a ventricle in one contraction or stroke, okay, times the rate. How many beats per minute? All right, how many strokes per minute? So peripheral resistance is basically friction of the blood trying to flow through the arteries. Now, we don't think of friction a lot of times, but there is friction anytime one substance is passing over the surface of another substance. And so part of that is related to how big is the artery that the blood is going into. The bigger the artery, the lower the pressure required to push blood through. The narrower the artery, the higher the pressure. Okay, that makes sense, I'm sure. Again, resistance goes up if the artery narrows, and therefore increases the blood pressure. Okay, so blood volume here is another component. The more blood, the more pressure on the artery walls, therefore the more pressure. Now, blood volume is tied very closely to blood pressure, to the point that one of the strategies for lowering blood pressure is to reduce blood volume. Now, these days we do it by chemicals. In the old days, they bled you. You got too much blood, we're going to let some out. Well, we're finding now that sometimes that's not a bad idea. People with things like polycythemia vera, have you heard of that disease? That's really sludgy blood because you have a very, very high red cell count. So the blood becomes thick and viscous. And so in order to deal with that disease, people with that disease need to go in regularly and literally be bled. They actually take blood out to reduce the volume, to reduce the number of red blood cells per unit volume. And of course, at the same time, they're replacing it with other fluids. Well,
there's too many.
Yeah, but that's a genetic issue too. But what you can do is, we do store packed red blood cells. I don't know if they save those or not, but just producing too many blood cells is not necessarily a contagious process.
If it's affecting this person, we should probably fit into this other. But we do,
Yeah. Yeah. But we do, yeah. Okay. So another part, besides the fact of the actual heart, cardiac output, blood volume, and resistance, we have what we call endocrine control. Endocrines are internal chemicals that have a biological function. And epinephrine increases all of these: blood, cardiac output, blood volume, and resistance. And therefore will raise blood pressure. It's a vasopressor. Norepinephrine is a precursor to epinephrine, and some of the epinephrine receptors bind actually better to norepi than to epinephrine. Has the same effect. The drug, or the internal molecule known as atrionatriuretic hormone. Natriuretic refers to reducing sodium. So ANH is released by cells in the atria in response to a stretching force. So it dilates, and ANH gets into the circulation and dilates arterioles. So it's a vasodilator. And it does, and of course, then it reduces blood pressure. Another major part of this comes out of the kidneys. So another system that's very intimately involved with the cardiovascular system is the renal system, the genitourinary system. In the kidneys, kidneys monitor blood volume, and they will release chemicals like renin. It's called renin because we first discovered it in kidneys, renal, right? Some people call it renin. That will convert angiotensinogen. And whenever you see the ogen ending to one of these biological molecules, that means it's a precursor molecule. It is a progenitor to something else. So it converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. And this is a very potent pressor. In other words, it raises blood pressure. It's much more potent than epinephrine. So the kidneys are involved. So among other things, when blood pressure problems occur in a patient, they can have renal effects as well. So we are starting to see how everything is connected to everything else. So there's a graphic here on slide number 21. There we go.
What the heck?
Trees grow.
Holy. That's what I was saying.
There's 170 some slides in this presentation, I think. 150. Yeah, yeah. Yeah, if I put one slide on a page, it would be.
This is the manuscript.
Yes.
Of the cardiovascular
system. Yeah, pretty much. And it's drugs and other things. There's a lot of stuff in here we're not going to actually cover in any detail. But anyway, slide number 21 is actually a pretty good diagram of the renin-angiotensin-aldosterone system of blood pressure modification. At the center is angiotensin 2. And angiotensin 2, as we said, the kidneys release renin. Renin changes angiotensinogen to angiotensin 1. ACE converts it to angiotensin 2, and then all sorts of things happen. It has effects on blood pressure by increasing volume, by changing renal sodium retention, by vasoconstriction, that is increasing blood pressure. There's an interesting, there are pituitary effects that as well, which also affect the sodium balance. Cardiac and vascular hypertrophy, in other words, getting larger, in other words, expanding. Hypertrophy is not good. So these are the effects that these things can have. So there's another diagram at slide 22 that talks a little bit more about another look here of how all these work. Angiotensinogen is generated by the liver, by the way, renin by the kidney. So now we're getting everything, everything involved. Most of our body systems involved in this process. Excuse me. So we're going to talk about various diseases of the cardiovascular system and how we treat them, I hope. Excuse me. That wasn't expected. Okay. We're going to talk about angina, hypertension, congestive heart failure, various forms of coronary artery disease, myocardial infarction, arrhythmias, and we'll move on to some other conditions that we treat, control of clotting factors, et cetera, that we have to do for our patients. Lots of different kinds of drugs. We'll talk about antihyperlipidemics, meaning cholesterol lowering drugs, antihypertensives, cardiotonics, things like digoxin that treat CHF, drugs to treat angina, anticoagulants, antiarrhythmics, quite a few. We'll start with antiarrhythmic drugs. An arrhythmia, or as we are now starting to call them, a dysrhythmia, is anything that's not a normal heartbeat pattern. It can be a funny kind of phrase, regularly irregular, meaning it can be an irregular heartbeat that is the same with every time the heart beats. So the irregular ECG trace is the same all the way down. It's just not normal. Okay, that's a regular irregular heartbeat. Pardon? It depends. It can be. Depends. We can have all sorts of different kinds of traces. The irregulars, however, are changes that occur seemingly at random. They're probably not fully randomized, but changes that occur seemingly randomly in the way the heart is functioning. Now, remember, an arrhythmia is something that is not a normal rhythm. So it's anything that isn't that trace that we looked at on an earlier slide. And we have the normal sinus rhythm, but arrhythmias can take many different forms. All of them have slightly different ECGs. And while people can have an irregular heartbeat, sometimes it's just the way their heart is working. There's still much we don't know. We've learned a lot, but there's still a lot we don't know. So what do we have? Types of arrhythmias are slow and fast heartbeats, bradycardia, tachycardia. Are these bad? Depends. We all have episodes of tachycardia. Anytime you run after your dog, your heart rate's going to increase. It's going to go fast. Normal heart rate, 50 to 70 heartbeats per minute. Okay? If you are a high performance athlete, your heart will beat slower because it's used to, when you're not performing, because it's used to pumping a lot of blood real fast, and it is used to pumping hard. So they also have higher blood pressure a lot of times. There's atrial flutter and fibrillation. These are rapid heartbeats. Flutter, fibrillation is just fast heartbeat. Fast to the point that you've gone past tachycardia into sort of an uncontrolled, not regular beating. Flutter is sort of little contractions. I don't know the answer to that. I'll give you that. I don't know. Why don't we look it up?
Google.
Look it up. Yeah, that's
not Google. That's the word.
It's all right.
Apple?
Apple?
Palpitations make you feel like your heart is beating too hard or too fast, skipping a beat or fluttering. Yeah, makes sense. Yep, same thing.
Okay. There's the answer to your question. Thank you very much. I'll know the answer next time it's asked. Fibrillation, however, is rapid and irregular beating. In the atrium, we can control that with a pacemaker. In the ventricle, it is much more dangerous. And what happens is when you have that kind of fibrillation, you start getting pooling of blood in the chambers because it's not sufficiently emptying the chamber. Pacemakers are used for atrial fib. Ventricular fib, we use an AED, a defibrillator. We now have implantable defibrillators as well as implantable pacemakers. And if the heart function is poor enough, you may end up with both. One of my sisters did, and we didn't find that out until she was dying, that she had both. Well, that's just the way it happens to be. She never told us either. We never knew it until even her daughter didn't know. So, no, I'm serious. It was, it was kind of a shock, So,
That's a different level
yeah,
that
tell
I
me.
haven't even surpassed yet.
Don't go there. Okay, that's my advice. We have ventricular tachycardia, which is just fast heartbeat. Again, we don't like to see that go on too long. And then there's something called a premature ventricular contraction, or PVC. This is when the atrium is still pumping and pushing blood through the tricuspid valve, if it's the right atrium, pushing blood through the tricuspid valve, and then the ventricle contracts while that's going on, and blood is pushed back into the atrium. Clearly, this is not good. So PVCs are something we want to try and control. This can be done chemically as well as, I think there are some electrical interventions. Now, some statements here, some things to think about. Abnormal rhythms almost always indicate ischemia. In other words, hello, Amanda. You're right at the right time.
So much pie.
Oh, hi, thank you. Thanks. Would you like another one?
Oh, sure.
Another? Why not?
Why not? Yes, thank you. Yeah, these are nice. All right.
Right? My grandpa loves apple pie, but because he has diabetes, it's hard for him to eat some without sugar in it. It's just like, and when I worked at Burger King, he always asked me when I came home, did you check if the apple pie had no sugar in it? And I felt so bad.
I'm gonna make your grandpa a no sugar apple pie.
Oh yeah, use
I have
applesauce to
loved
sweeten it.
forever.
Yeah. Yeah, my aunt used to, or my wife's aunt used to, when for her husband who was diabetic, used to make him apple pies, and she'd sweeten them with applesauce.
Really?
Yeah.
I'm gonna have to try that.
Yeah, it works pretty well. They taste pretty good too. Of course, yeah, they are cute, aren't they? She just couldn't stand it, had to eat it. Yeah. Yep. Pi Day is today, 3/14, 3/14. You know, and Charity and Layla are missing out. Not that Charity probably misses it, but anyway, that's the way it goes. Anyway, so we have um, there are different ways of looking at the intervals. I'm not going to go into those on the ECG trace since you haven't had the class yet. This isn't an ECG class, but there are all sorts of things that will appear. As I said before, the atrial fib can be is dangerous because you really don't get blood completely ejected from the chamber. Same with ventricular fib, and then it begins to clot. When you get clots, that's when you have heart attacks, strokes, pulmonary embolisms, etc. Yeah, basically. VFib is something that when I was a kid, we had a lot of medical dramas on television. They were real popular for about 5 years. And we'd always hear of somebody yelling about VFib and get the AED or inject this or that.
Grey's Anatomy. Which one of Epi?
Yeah, right. Right. And it's right to be worried because it can quickly lead to heart failure, heart death. The VTAC is something that happens a lot of times. It can be dangerous because the ventricles may be contracting faster than they're getting blood from the atria. So you may find that blood is not getting pumped very efficiently. As I say, with fibrillation and other ventricular problems, we can use defibrillators. Okay. Okay, drugs. Let's talk about drugs.
Yay.
That's what this class is about. We have drugs for treating these things. Remember, all of these different things that can go wrong with the heart do go wrong with the heart. Fortunately, not in everybody, but they do go wrong with the heart. So we have various classes of antiarrhythmics that will do that will help reduce the speed of the rate of contraction or increase the rate of contraction by blocking various chemicals like epi and norepi, or by blocking the electrical signals when in the heart. We have calcium channel blockers, which prolong that repolarization phase and slow things down. We are potassium channel blockers that do that, rather. The calcium channel blockers also will do that with a different type of efficiency. And depending on the patient, you would choose one or the other. There are other drugs we use. Drugs that are very much related to local anesthetics. Obviously, local anesthetics work by blocking nerves. And so it makes sense that if you have an electrical problem, you might be able to affect it with an injection of an anesthetic of some sort. You don't want major anesthetics, but we're talking about things like lidocaine or procaine amide, which is Novocaine. Yeah, right. We have beta blockers, which block, basically they block epinephrine and norepinephrine as well. There are plenty of drugs. But one thing to remember, if you're working in a cardiology office, drugs always have a downside, and many times drugs will cause the very thing that they're trying to cure. For instance, in this case, all antiarrhythmic drugs can cause arrhythmias because they're modifying rhythm. So if they're used to a patient with a normal sinus rhythm, they can cause a dysrhythmia to occur in those patients. Yep. Well, it does. We're messing around with the very chemicals and the electrical signals that cause heart contraction. So, a drug that is often used, an administered IV can be adenosine, that is used to treat certain forms of tachycardia. Very short-lived, but it's an emergency drug. We're looking here at slide number 35. We're looking at, again, a normal sinus rhythm on the right, on the left, and on the right, an abnormal rhythm of fibrillation, atrial fibrillation. Note the differences there. They're really obvious. The one on the left is very much a regular rhythm, and the one on the right is it is a rhythm that in this very, very short segment looks like it's regularly irregular, but in a longer segment it might not. Okay. Okay. It's now almost 7 o'clock. So rather than go into the next topic, let's take a 15-minute break. And I'm going to stop the pause the recording. Okay, let's get started again. You take a silly pill on break?
Always. Every day.
All right. Good. Silly is better than nasty. So let's have that. Okay. One thing I wanted to remind you, have you guys done your FAFSA for this year yet?
No.
I will remind you to see Kelly.
I have about 8 times because of my mother.
So you're working on it.
No. I'm not.
So how are you going to pay for school?
I don't know. Yeah, that's the place that I'm at.
Talk to Kelly about alternatives.
When is the graduation?
When are you supposed to graduate?
Never.
September.
September.
Okay.
According to independent. So that could be August or like February. Yeah.
Well, actually, if you're making normal progress, which I believe you are, you probably graduate on time.
Normal progress except for I know filming the first time, so I can take that's the only thing. But that's good.
Yeah. So you're taking that course, Med 108, this mod with Tel, right? Okay. All right. What do we got here? A chat. We usually start, this is a question from Charity, so I'm answering Charity. We usually start on FAFSA at the beginning of the year. So I don't know. If she was working on FAFSAs in December, it has to be for this year. So that's all I can say, because FAFSA has to be done by mid-year. And yeah, but usually there's a month's grace period on that. We usually start getting excited about May 1st, trying to get everything done. So anyway, it's the best best answer I can offer you, Charity. So you might email Kelly and just ask. Okay, let's go on and talk about now another class of drugs, the anticoagulants. Anticoagulants prevent clotting. Coagulopathies are any irregularity in the clotting process. And you remember from your A&P class, the clotting process is a multi-stage process involving many factors, protein factors, as well as non-protein like vitamin K. And the clotting cascade can be modified anywhere in there, in that line, or another aspect of the healing and clotting process is platelets. So we can prevent platelet aggregation, which is, as you recall from healing, that's the first thing that happens is platelets start moving to the lesion. And then all sorts of things like fibrin get generated, and then we start getting cellular debris and other things that get caught up in it. The opposite of preventing clots is actually dissolving them once they form. And we do that with thrombolytics. Remember, clot is also known as a thrombus when it's inside the body. And when it's outside the body, it's a scab, right? So we have those kinds of processes going on. Why do we care about coagulation and about anticoagulants? For a normal person, we don't. However, there are many people who have problems with spontaneous formation of thrombi within the body. And this happens with several reasons. One of them is that we get minor injuries. Minor injuries will then provoke a response. And if occasionally the plaque, the thrombus that forms, will start to break up, and particles will start circulating in the blood. We call those emboli when they're on the fly in the blood. And they can go places like the lung, the heart, the brain. Actually, they can go to any area of the body where we have a narrowing of the blood flow. And that includes arterioles and even capillaries can be blocked anywhere in the body. Occasionally that can be painful, but most of the time we don't even bother to notice. But it happens. So what happens with many of these is in the veins of the leg, coming off the femoral veins, the deeper veins within the leg, the major vessels returning blood from the lower extremities to the heart, we will form thrombi. We call these deep venous thromboses, and a lot of people have them. They result in a narrowing of the vein and then a restriction of blood flow. If that blood flow is cut off, then you get things like the picture on slide number 39. That's a person whose right leg has a thrombosis, a thrombotic closing of a blood vessel, and then swelling and discoloration of the skin. This can go, this color here is relatively, is a fresh, basically a fresh thrombosis. It will turn black. It'll be like the biggest bruise you ever saw. And it may or may not heal up. One of the ways that we can prevent these is exercise, just walking. The process of exercising and keeping the blood flow then eats away bits and pieces of these thromboses. We can also use doses of thrombolytic drugs to gradually break it up. But what happens with these things is that if a piece breaks off, goes to the heart, where's it going to go first? It's going to go to the lung. When it lodges in an arteriole in the lung and cuts off blood flow, then that causes lung tissue to become infarcted, basically blocked, and die because, of course, there's no blood getting put. Okay, so, and we're not getting any exchange of gas. I am told that pulmonary emboli are very painful. Fortunately, I have no experience with them. I'm pleased to be able to say that. But anticoagulants are given to prevent additional clotting. Anticoagulants per se do nothing to reverse the clotting process. What they do is allow the body to gradually use its own chemical anticoagulant cascade and efforts to wear it away. They are often called blood thinners, but they really don't thin blood at all. What they do is keep it from clotting. The most common is warfarin or Coumadin. It's an oral anticoagulant that's taken by virtually anyone who has an implanted device, whether it be a pacemaker or a shunt, say for a brain injury, or actually for other implanted devices. The mechanism is that it interferes with vitamin K dependent factors. So warfarin is given for oral use. It's taken once a day, and you have to be tested every year for your clotting factors, what we call the international normalized ratio, or INR. These days, we actually have a CLIA waived test, like the glucose test, like several of the others that we have, that can help us determine this INR very, very quickly. But most of the time, if you're on warfarin, your doctor wants to see you, especially if you're of any age. Parenterally, we have heparin and forms of heparin. Heparin is a natural product. It is a complex material that is injected. There is a low molecular weight form, Lovenox, that's also injected. Either one can be given subcutaneously. Mostly they're given subcutaneously, but they can be given IV. And heparin is also used to keep indwelling venous catheters from clotting. We call it a HepLock, by putting a little of that in there to prevent clotting. The Coumadin, as I say, is one of the common drugs. It's really a very commonly prescribed drug. There are lots of different strengths of Coumadin because the dose varies from very small doses to much larger doses. Most people will take a dose that varies during the course of a week because they need intermediate doses. It has a long enough half-life that it can be taken once a day. And most people, once they get acclimatized to the drug, as long as they take it regularly, they're relatively well controlled. What you'll find with a warfarin patient is that they'll go in and they'll get their initial prescription. You'll go back a month later and have a blood draw, or actually in the first couple of months, you might go back a week or two later and get a blood draw. A test of that will give a test of the clotting factors, the INR, will then tell people how efficiently your blood is clotting. They try to adjust it so that you don't have too much on board because you don't want your INR to be too low. Because what happens then is you bleed. You bleed from minor things that you and I would look at and say, oh, just forget it. It'll stop bleeding in about 3 seconds, and usually does. Yeah, paper cuts or, something like that. A little scratch. But people who are on warfarin tend to bleed easily and for a long time, and they tend to bruise easily. We know a lot about it in our house because my mother-in-law is taking warfarin because she has a pacemaker. So we watch that fairly closely. She is one of the lucky ones. Well, lucky. She's one of the better patients because she's very well controlled on her warfarin. The problem is you have to go in once a month for a blood draw, and a lot of people don't like that. And this has led to the development of other products. Now that we have ways really of developing a lot of kinds of products, there are several other drugs that are not warfarin, that are not based on vitamin K inhibition, drugs like Farxiga, Xarelto, Eliquis. These interfere with other parts of the clotting cascade. Most of them interfere with factor 10 or factor 10A. The problem is with warfarin, if you get an overdose, you just go to the ER, you're bleeding, yes, it's uncomfortable, but then you get a shot of vitamin K, and that reverses it. There are no rescue agents for these other drugs that have been developed. And since they're developed as a fixed dose, there is a significant risk of overdosing. I read a study a number of years ago about looking at the levels of anticoagulant activity in patients taking some of these drugs, and the estimate was that 75% of the patients were either overdosed or underdosed. If you're underdosed, you still have too much clotting, and you have the risk of stroke, heart attack, etc. If you're overdosed, you have the risk of bleeding. If you can't reverse the drug, which they have no way to do, then you have to have supportive care. There have been a number of deaths on those drugs. And I have to admit that I have a very poor attitude about those drugs because my mother-in-law's cardiologist down in Denver was trying to get her to switch to Eliquis for a long time. Oh, what a wonderful drug it is. And I never trusted it because she was well controlled on warfarin. She'd had one major bleeding issue with warfarin, and that's because the pharmacy gave her the wrong strength tablet. And she didn't notice, and we weren't living with her at the time and monitoring things. Now we look. We look carefully at everything that comes in the door. She's good with her meds, but she doesn't understand meds. She's good at taking them, but she doesn't recognize when she's got the wrong dose. So we watch that closely, and then leave her alone to take her drugs, which is fine. But what they did was we told him, no, you will not put her on this drug. I don't trust it. And he argued with me at one point, saying, "Well, they're developing an antidote for it." And I said, "Yeah, I know they are. And yeah, the key is they're developing. It's at least a year before it'll be submitted to the FDA, and it'll be at least 2 years after that before we see it on the market." So the answer is no. And don't bring it up again. But they nagged her into it, and she was considered competent to change, and she switched without telling us. And that was deliberate on her part because she knew we were opposed to it. So she switched without telling us. And then she had a major bleed. We were in the ER 3 times in 3 days. They installed what's called a rhino rocket, which is a big tube that they stick in your nose. She used to get what they referred to as digital trauma. She'd pick her nose and break blood vessels and bleed. And so they stuck this thing in there, and they had to reinflate it twice because it wasn't inflated enough to pressure close the blood vessel. And after that, we went back to the doctor and said she's going back on warfarin if you want to keep her as a patient. Basically, we've got either it's warfarin or a new doctor who will put her on warfarin. So which do you want? She went back on warfarin. Has been on it ever since. She is remarkably well controlled. But these drugs are out there. They're very expensive. They're being pushed very hard by the pharmaceutical industry, and there are class action suits about every single one of them. Well, yeah, there is. But in this case, I happen to agree that it's reasonable because patients are dying because they bleed to death taking these drugs because there's nothing to stop the action of the drug. And of course, you don't know they're bleeding until they've got a full dose on board. So you got to keep them alive for whatever the half-life is. And most of these are once a day. So they've got drug in their system for a couple of days. So it's not really good. The heparin, material that, the injectable material, and low molecular weight heparin, which like Lovenox, are very safe. Heparin itself inhibits formation of the fibrin side of clotting, and it also has an inactivating effect on several other clotting factors. Has to be injected. The same with the low molecular weight. Lovenox actually comes with its own auto-injector. It has some advantages, and that patient stability is actually better on Lovenox. I'm going to switch now. So we use them for prevention and treatment of both deep venous thrombosis and pulmonary embolism, and also to prevent the development of thrombus formation after surgeries of a number of sorts, or when patients have implanted devices in place, like defibrillators and pacemakers. There are not a whole lot of things that can be done for patients who are at risk of developing these clots, other than to try and keep them from forming. As I said, none of them will dissolve an existing clot. That's reserved for the thrombolytics, but they will prevent expansion of clots and prevent new clots from forming. Antiplatelet drugs are used. There's a number of those. The most common antiplatelet drug is aspirin. That's how aspirin prevents heart attacks. What they do, platelets obviously are going in and forming a thrombus. They have to stick together. What aspirin and the other antiplatelet drugs do is make them slippery, so they don't stick together. That's right. They try to form a clot and they just fall off and go circulating. So patients are taking these. There's several. Besides aspirin, there's Persantine and Plavix. that are used. They do, of course, have side effects. But these are used to prevent clots from forming and prevent the downstream effects of clots, MI, stroke, and related diseases. Okay. Thrombolytics. Thrombolytics are drugs that dissolve clots. And they can open up clot-occluded vessels. They are used for treatment of acute MI, pulmonary embolism, and advanced things of like the deep venous thrombosis, where we're starting to see the ischemia, the swelling and edema that we saw in that picture there. They work by literally activating the downstream processes of dissolving a clot. Emily.
Do they have you get up and like walk around to start encouraging more blood flow, or is it just like stay in your bed?
Well, it's going to depend.
Yeah.
I mean, one of the best ways once a person has a blockage, what we don't want is to give them a thrombolytic and have them move around and break off a big chunk of it. So there's a lot of different things that are done. One of the reasons that we use TED hose is to keep pressure on our lower limbs to push blood through and keep the blood from pooling and then expanding, things like DVTs. Some of them are pretty big. You can have occlusions that occur that can be very, very painful. Circulatory painfully. We also use them in treating stroke and heart attack. The original thrombolytic was a bacterial protein called streptokinase. It was isolated from streptococcus, and it's a protein that initiated a lot of thrombolytic activity. The problem is, as a bacterial protein, you could use it once because people would then be allergic to it and wouldn't respond. They'd have antibodies to it. So it wouldn't work. Pardon?
I said it makes sense.
Well, yeah, so it worked. So in the 1980s, with the discovery of tissue plasminogen activator, plasminogen is one of the factors that plasminogen obviously generates plasmin. Plasmin is one of the factors that helps dissolve fibrin clots and break up clots. Was developed for treating specifically heart attack at the time, and it was very effective. The problem is you need to give it within a relatively short period of time after the clot, actually after the event, the MI or the stroke. And we're refining that treatment now to where we've extended the time that we have. And part of the reason is, of course, you don't have your heart attack, generally speaking, when you're sitting in the ER. You have it at home. You have it at work. You have it on the ski slopes, right? You got to get to the hospital. So time is a major factor. Obviously, if you have it and somebody's got the ability to dose you within minutes, much better. But now we know that we can do this. your PowerPoint talks about that it has to be given in a hospital setting only by experienced critical care providers. Yeah, you want critical care trained people. We can actually give it in other locations besides hospitals now. The major advantage to TPA, tissue plasminogen activator, is it's a human protein. So we don't expect to have the same kinds of allergic reactions as we do or urokinase, which is another thrombolytic. The contraindications, well, any bleeding disorder, obviously. You want to avoid giving things like anticoagulants. We need to know our patient pretty thoroughly. With thrombolytics, we want to be careful that with the dosing, we want to be careful that we're not going to dislodge existing plaque like DVTs or whatever and cause a downstream problem with that. So on the other hand, sometimes you don't have a choice. You have to save the patient and take your chance.
So would I have like less of a chance of a clot, or is it?
No, you still have other things in your blood. I mean, yeah, if your clotting time is bad, you would want to first off look at what you can do to enhance it. Yeah. How does that do? How does that affect your stomach? You don't have a problem with that?
Not anymore.
Okay.
When I first started taking it, it was
Yeah,
like
yeah.
every day. Almost heartburn, almost acid reflux type feeling.
Well, iron is a toxic metal.
Yeah. So no, when I take it every day now, I've been for 11 years now.
What supplement are you taking?
I don't remember the name of the new one that I got. It's just a Kroger brand. I think it's 60.
Well, that's an amount. What I'm concerned about is the form of the iron.
It's a.
Okay, yeah, obviously we're not talking the same thing. I'm talking about chemical form. Okay, yeah, you would know, right? Okay, so if you have clotting issues, then you should be eating plenty of green leafy vegetables, spinach and that sort of thing because of the vitamin K. You want that. Well, that's probably why. You do. So you want to look at that. If I were you, my bias is going to come out here. If I were you, I'd see a naturopath. And supplement whatever your allopathic doctor is doing to help you with looking at dietary and other natural ways of improving clotting. There are methods that can be done. I'm not a naturopath, so I'm not going to go there. But I would consult one personally. Uh-huh. Okay. 65. Okay. 650 sounded high. Okay. Yeah. Okay.
I don't know.
Yeah.
I'm trying to read the back.
Yeah. Yeah. Well, ferrous sulfate at least is usable. Okay. But that, as I say, I would look at some other alternatives to helping the clotting function. Anyway, let's talk about anti-anginal drugs. Angina is a condition, a painful condition, which is characterized by a decrease in oxygen supply to the heart, usually by an atherosclerotic plaque formed in the coronary arteries. Okay. There are several different types of angina. Exercise-induced angina is not uncommon. And I always think, when people say they get angina after they go to the gym, I often wonder why they don't just take a 20-minute walk instead, because that actually, all of the exercise research shows that in terms of cardiac function, a 20-minute walk is as good as a workout in the gym. Yeah, I know. And I can't blame them for that. It helps keep up strength and everything else. I do that just because I want to try and keep up strength, because as you get older, you get deterioration of the muscles. So, yeah, it happens. Yep, that's right. It's called the normal course of life. It's called the only way you get out of that one is to die. So anyway, there is also a form of angina that occurs at rest. And we have unstable angina that can just occur under any circumstances. That's usually very risky. It's usually is something that leads to a heart attack. But note that it is characterized by starving the heart of oxygen. Angina occurs when the oxygen demand exceeds the supply. Okay, and that's defined as ischemia. So what happens is we see changes on ECG. We see a depression of the QRS wave there, and that indicates ischemia, or the ST segment of the QRST section of that. Most common drugs, nitroglycerin, but we also have things like isosorbide dinitrate, amyl nitrate, or amyl nitrite rather. These are all capable of relieving the pain by the simple release of nitrous oxide, which dilates blood vessels. That's the mechanism by which that happens. It's a very potent vasodilator. These drugs are generally given by sublingual spray or transdermal routes. They can be given by injection in an emergency. So these things work pretty well, but we have to make sure patients understand that they cannot swallow them or chew them. They allow when they take them, especially the sublingual, when they take them, the little tablets go under the tongue and essentially disintegrate immediately and release the drug for absorption through the oral mucosa. We can use acute attacks are often treated either with inhalation of amyl nitrite or through injection of generally nitroglycerin, and to really affect a reduction in the symptoms. We can take drugs to prophylactically reduce the symptoms of angina. The most common way is to use a NitroDur patch. A transdermal patch is the most common. We have other drugs as well. What are the adverse effects? Well, you can get when you dilate the blood vessels, you get a sudden drop in blood pressure and you get dizziness. That's one of the things. Headache as well. You can actually faint if you suddenly reduce suddenly relax the arteries and go into hypotension. So it's a good idea for patients to be either lying down or seated when they take these drugs, because if they pass out, you don't want to be picking them up, especially if they weigh 250, 300 pounds. We also can use beta blockers to decrease the workload on the heart and therefore decrease the oxygen need. And a lot of times patients who are prone to angina will be put on beta blockers to prevent that. Beta blockers are also used in as primary drugs in the treatment of hypertension. They were originally developed for hypertension. And we have a number of those things. What they do is reduce the heart's oxygen demand. This is how they help deal with blood pressure and by reducing heart rate. So they help control blood pressure. There's lots of things here about beta blockers, but we're not going to go through all of those. Calcium channel blockers are used to control contractions of the heart and to dilate the arteries. When we reduce the workload of the heart, we also can help treat blood pressure. And they can also be used to treat prevention of angina and cardiac arrhythmias. So they're very important drugs. Calcium channel blockers, there are a number of them. They have alternative uses as well, including drugs like verapamil can be used to treat tachycardia type arrhythmias. And nifedipine can be used for reducing, also treating angina and a couple of other conditions. Side effects: hypotension. Anything that lowers blood pressure could have a side effect of hypotension. There can be GI and other reactions. And as usual with all kinds of drugs, allergic reactions. So antihypertensives, there's a little cartoon here about things to watch out for. When dealing with these kinds of drugs, we continuously revise the treatment protocols for hypertension as we get to understand the interaction of these drugs. We'll move on now to congestive heart failure. Congestive heart failure is when the heart simply cannot sufficiently beat at a rate to meet the needs of the tissues. In other words, the cardiac output is just not able to maintain. So we need to intervene in that. Patients with congestive heart failure often have other cardiac conditions, arrhythmias, history of heart attack, blood pressure issues. They could be drug-induced as well. But congestive heart failure is, again, it's a sort of a description. Basically, your heart isn't working right. It does need to do that. The kinds of drugs that we use fall into the class we call cardiotonics and inotropic drugs. These are drugs that work to correct and keep the heart pumping properly. They can do this several different ways. If we look at a heart failure patient, they often have problems breathing. They have orthostatic problems. They can't breathe unless they're sitting up. They have lots of breath sounds. We talked about crackles and wheezes, about the respiratory. They often have that. So quite often CHF is accompanies COPD. Blood pressure, pardon? Yeah, it is. All sorts of things. Now, not everything happens, but they also have trouble keeping up their oxygen saturation. We have to monitor that on a regular basis. What we have with congestive heart failure, we have an X-ray picture here of a normal chest X-ray, and then a chest X-ray of a patient with CHF. They have enlarged hearts, sometimes significantly, and then a lot of fluid buildup in their lungs. Treatments include some beta blockers, diuretics. Obviously, we're trying to get the fluid load down. Vasodilators, let's get that heart not having to work so hard to pump blood by expanding their vasculature. But we also use digoxin. Digoxin is the prototypical inotrope. Digoxin is a drug that has been used for 300 plus years. It's an isolated component of the leaves of the foxglove plant, Digitalis purpura, which is a very pretty blue leaf plant that if you eat it, it's toxic, because digoxin itself is poisonous, is a toxin. Interestingly enough, digoxin is the reason we have child-resistant containers for drugs, because children would get into the medicine cabinets at their parents' or grandparents' home and find the little bottle of digoxin tablets, and they look like candy. So they'd eat them. They'd swallow a handful. And so for a while, back in the 60s, one of the most common calls to poison control centers was, my 4-year-old just ate, 20 of his grandfather's digoxin tablets. Now, fortunately, we can almost always, if you catch it right away, it's really fairly easy to treat. But what it does is increase cardiac output by increasing the force of the contraction. So that's why using a vasodilator is a good idea as well, so that it also slows the heart rate. So you want the blood to be able to flow more easily through the vasculature. Dig is a very good drug. There's a nice picture here of the flowers of a foxglove. It's a very attractive plant. Plants have been very, very good about giving us drugs over the years. The digoxin is one of those drugs that largely isn't metabolized by the body. It just gets eliminated in the urine. Again, we use this drug carefully, but since it's been around for 300 years, we understand it. It is one of those drugs that has a very narrow therapeutic range. In other words, the distance between the therapeutic dose and the toxic dose. It also is an extremely low dose drug. We dose this thing in microgram amounts. Daily maintenance is something that most patients have when they go on DIG, and they stay there. DIG has been around. There have been many attempts in the pharmaceutical industry to displace it with, quote, better drugs. And every study that I know of that has been done comparing DIG to some other agent that's supposed to do a better job, the DIG always has better outcomes. And that's all cardiologists care about. We had a neighbor when I was in North Carolina who was a young cardiologist, and he told me one day his favorite drug was digoxin. So because they like it. Digoxin has a lot of other adverse effects. There can be changes in heart rate that are not what we want, leading to arrhythmias. Patients first going on the drug often have trouble with headaches and dizziness and nausea and other disturbances. But generally speaking, after they are regulated on the drug, they go away. Overdose, nausea, vomiting, severe. It can also cause ECG changes. If it's caught early, you can either discontinue the drug for a few days and just keep the patient going. Or if it's light threatening, we have a product we call Digibind, which is an antibody product that is the antidote for digoxin overdose. It's a fragment of an antibody. Works really well. I remember when we developed it. CHF can also be treated with diuretics. Diuretics are water pills, right? There are a number of those. We can use vasodilators. We can do a number of different things. Again, cardiovascular disease is almost never monogenic. There's almost always a cluster of events going on with the patient. So we have to look very carefully at our patient, and sometimes we just have to experiment with what treatment's going to work best on the patient because it's very difficult to predict that. We'll move on now to coronary heart disease or coronary artery disease. We have arteriosclerosis, which is known as hardening of the arteries. This is a reality. The arteries become less elastic, less able to take the pressure changes that come with the pumping of the heart. Or we have atherosclerosis, which is the buildup of plaque in the arteries. It's coronary artery disease when there are the heart arteries. And obviously that affects the ability of the heart to work. Severe enough coronary artery disease, if it's atherosclerotic, we can go in and try to clean it out with angioplasty, which gets threaded up through the femoral vein into the heart. And then we basically mechanically remove. We can do balloon angioplasty, blow it up and just basically beat the thrombus into little pieces and have them small enough that they just circulate out. That works. And if it's severe enough, we have to do bypass grafts strategies. Coronary artery disease, we're going to move from there into a discussion of dyslipidemias. We used to talk about hyperlipidemia, et cetera. Now we use the term dyslipidemia, which means a change in the ideal balance of the lipids in the body. Lipids are composed of cholesterol, and triglycerides. Triglycerides are the way the body stores and transports the long-chain fatty acids. Triglycerides, by the way, is what you have in that bottle of olive oil on your shelf. Those are all triglycerides. They are the plant long-chain fatty acids that are being kept in solution by being attached to molecules of glycerin. All of our fats and oils in our body are, for the most part, triglycerides. Plaques are made up of the cholesterol that is carried in two different forms: low-density cholesterol, low-density lipoprotein, and high-density lipoprotein. What happens is these things deposit and are and cause blockages of our blood vessels, and then we have a problem. We have a picture here of what goes on. Now, HDL, you've all seen the blood reports. They talk about HDL, LDL, total cholesterol, triglycerides, and the ratio of HDL to LDL. LDL is called the bad cholesterol because LDL is what makes up is the majority of what makes up the plaque in our arteries. HDL we call the good cholesterol because it carries LDL away from these plaques and keeps it away from the arteries, and so actually keeps arteries clearer. But there are limits. If we look at our amounts of cholesterol, you all know that your total cholesterol ought to be below 200. You probably also know people whose cholesterol is not below 200. Some people are naturally high. When developing an anti-cholesterol drug, generally speaking, we want to deal with moderate elevations in cholesterol. As you get above about 300, and this is milligrams per deciliter of blood, if you get above 300, then there's a high likelihood that it's a genetic disease. It's familial, in which case your drugs aren't going to work, and there's little you can do about it. But we want our total cholesterol to be below 200. Our LDL should, of that 200, should ideally be below 130. And our HDL should be between 40 and 60. So what we want to do is look at these. And our first line of defense against elevated cholesterol is diet and exercise, and I'll nag on this forever, stop smoking. Smoking is bad for you, not just lung cancer. So anyway, I know you are. I know you're trying to quit. Pardon? I bet. Yeah, it's not funny. Okay. And then if changes in lifestyle and diet don't help, then doctors will consider drugs to reduce the level of cholesterol. There is some recent research that indicates that maybe we are a little off base in our concern about cholesterol. The body produces what it needs. We should probably limit our dietary cholesterol because we just don't need it circulating. The cholesterol goals, LDL, it would be great if it were below 100. Given an American diet, that's kind of hard. 100 to about 130 is in the range that's okay. Above 130 to 160 is considered borderline, and then above anything above 160 is considered high. If it gets up near 200 of just the LDL, it's very high. Total cholesterol, as I said, we want it to be below 200. HDL, we want it to be above, we want it to be in the range of 60. 40 is too low. I don't know what the upper level is. I'm not sure that we've established an upper level, but 60 is where we'd like it to be, 60 or a little bit more. So the issue is, of course, diet, exercise, and stop smoking. There are a number of different kinds of drugs. There are 4 classes of drugs and 1 sort of natural product. The 4 classes of drug are the statins.
It was 17.
That's good. That's good. Are the statins? These are called HMG-CoA reductase inhibitors. HMG-CoA reductase is an enzyme in the cholesterol biosynthetic scheme. Bile acid resins, fibrates, absorption inhibitors, and finally vitamin B3. And vitamin B3 probably ought to be off the list. I think it's been pretty well demonstrated not to work. All anti-cholesterol drugs are category X pregnancy because you have a developing fetus. Do you want to interfere with their ability to make cell walls? No, bad idea. Also, shouldn't be breastfeeding women should not either, because who are you breastfeeding? Your infant who is still growing and who needs cholesterol. So you don't want to be messing up cholesterol metabolism. The statins are some of the most popular and broadly selling drugs on the marketplace. We're constantly running into new guidelines on these things. They work in the liver. So obviously liver disease is a contraindication. Bile acid resins bind with cholesterol in the intestine and basically prevent it from being absorbed. It just gets excreted in the feces. The fibrates actually work to lower they lower the production of triglycerides. We want those below 140. Lower production of triglycerides, and then increase the excretion of cholesterol from bile into the feces. They work pretty well. The absorption inhibitor, there are absorption inhibitors as opposed to the sequestering agents. What they do is they block the ability of the cholesterol to be absorbed in the gut. In terms of, let's take a look at what happens if we have a blocked artery. We have an MI. About 40% of MI patients die before they can get to the hospital. I read a statistic one time that said about 70% of people who find out they have coronary disease find out by having a heart attack. Most of them die. So it's one of those things that often we don't have any idea is happening. And the drugs we use, obviously one of the preventive factors is taking aspirin. Everybody talks about baby aspirin, but the research shows us that unless you're allergic to aspirin, you get the same protection from a baby aspirin as you do from a full aspirin. Now, why would you take a full aspirin? Well, because it's a heck of a lot cheaper than a baby aspirin. I mean, that's my take on the topic. So we have, when we're treating a patient for MI, we want them to get oxygen right away. One of the leading causes of cardiovascular disease is hypertension. We have lots of hypertension drugs. The factors, the number of different systems in the body we talked about. You saw many targets: calcium channels, angiotensin 1 and 2, angiotensin converters, angiotensin receptor blockers. There are a whole wide range of drugs. Usually we'll start with something simple like a diuretic, but we'll take a close look at patients and see and make a guess. You did your Framingham Heart Study, so you know you've read all this. You know that it was a method of determining risk, not whether you were going to, but the likelihood, the elevated risk that comes, and it's used as a tool to get people to change their lifestyle. Antihypertensives, diuretics, beta blockers, the centrally acting alpha blockers, calcium channel blockers, angiotensin 2 receptor antagonists, ACE inhibitors, vasodilators. All of these can be given. There are patients who are taking every single one of those classes of drugs to control their blood pressure because they have complex disease. There are all sorts of places for them to act. The diuretics generally act at the level of the kidney, the nephron, and they're diuretics that act in every part of the nephron and do different things. They can also, what we are worried about is loss of electrolytes, both sodium and potassium. And so what we have, many patients are given potassium sparing diuretics. In other words, something that's not going to reduce the potassium, which is critical for heart function. So we have those. There's a lot of information here about these different kinds of drugs. You can go through this. Blood pressure is constantly, every few years, we get a new set of guidelines for what we want to do. Blood pressure used to be considered high if it was above about 150 systolic. Now we consider it, we recommend a blood pressure less than 140 over 90, 140 systolic, 90 diastolic. Drug companies are pushing an idea of a pre-hypertension at 130. That sells a lot more drug. I'm not sure it actually helps any patients. But the recommendations currently are to keep it under that. The statins are getting a lot of play, and largely because the drug companies are pushing them. Statins are not necessarily the best choice. Some of the recent research shows that statins don't work very well in women. And new testing on the actual, we talk about high density lipoprotein, low density lipoprotein, but there aren't just the two. There is a whole spectrum of particle sizes and densities. And right now we're finding that in order to choose the right drug and the right treatment for increased cholesterol, statins don't work depending on what that profile. You can have a test that's done. It's not covered by most insurance, so you get to pay for it out of pocket, but you can get a full, if you have mildly elevated cholesterol, it's probably worth doing to see what is the distribution, what is the particle profile, and that profile will predict what, if any, drugs you should take. For instance, my wife has mildly elevated cholesterol. She gets real mad at me. My cholesterol is depressed. But she has mildly elevated cholesterol. Yeah, and I eat a lot of butter and cheese and things like that. It's just natural. I get, you know, I get that genetically. But the Emily striptease starting again. But guidelines are coming out, and there's really the evidence isn't all that good for a lot of these drugs, and statins just don't work on a lot of people. Okay, so that's where we're going tonight. So I'm going to cut it off here. I know that we have Layla and Charity online. I know also that Perla is out of the country and is trying to watch. So although Emily and Bree and Charity and Layla don't have to do this, Perla, send me an email, and what I want to see in the email is the word Sydney, Sydney. That will tell me that you listened to this video, and we'll get you some attendance points. So looking forward to seeing you all on Monday. Charity, I will set up another one of these video sessions or Zoom sessions for Monday evening, and you can just log in. So everyone have a good weekend, and we'll take this up again. You have the problems there. Okay, I missed your question, Charity. At about 7:30, do cancer patients take warfarin? No, not necessarily. Most of them are not. Most of them do not have coagulation problems, though some of the drugs can lead to that. It's going to depend on what chemotherapy they're taking. Or after surgery, they might. So I hope that helps. Anyway, we will see you all on Monday.